Hi. I hope you are enjoying the lunch, and thank you for staying around. Our next speaker is going to speak about the Taiwanese model. The talk is about a single-payer system. Dr. Chi-Man Winnie Yip is a professor of the practice of international health policy and economics at the Department of Global Health and Population, and is the director of the China Health Partnership at Harvard School of Public Health. So welcome me in inviting her to come and speak. Thanks.
Thank you. Good afternoon. I know what a challenge it is to speak while people are enjoying lunch. So I'm going to make this entertaining if I can. Now, I'm going to take you a little bit away from OECD, advanced economy, to further away to Taiwan. But as I speak, you will realize that a lot of the design features in Taiwan and also the challenges that Taiwan faces is very similar to the three systems that you have heard this morning. And one of the reasons is that in 1988, when Taiwan started planning its national health insurance system, what it did is that it brought experts from precisely the US, the UK, Canada, and Germany to learn about from each system what they can take and also what to not do, which is pretty much the US system. So the US system was there as a mirror of what you should not do. And so there are similarities that you will hear, and in fact, many Taiwanese colleagues would always introduce their health system as we have our healthcare system is like a car that is built with parts from 4 other different countries. And that's UK, Germany, Canada, and the US. And the title of today of my talk is what a single-payer system can achieve, but also, of course, I'm going to share with you what are the challenges and difficulty of what a single-payer system might be, using Taiwan as an illustration. I know that the discussion of single-payer has been off and on the table in the US, and it has now become very politically charged as a topic. But I'm trying to present it more as a technical presentation, and then I'll leave it for discussion. So some background. Taiwan established a national health insurance system in 1995. And what are the objectives that was declared when it was established? It was very clear there are 2 objectives. The first objective is to assure equitable access to good quality health care for all. There's a very strong focus on equity. And it would come through in my description of how they designed the system in terms of its financing and also the delivery. But Taiwan also knows that in order for the system to be sustainable, it also has to design it in such a way that it is financially sustainable, meaning that the healthcare expenditure need to be managed effectively. Otherwise, it will not be available for the long term. So those are the 2 health goals that were declared. Let me just quickly define by what I mean by a single-payer system and how I'm organizing my talk when I'm describing Taiwan's single-payer system. I define Taiwan as a single-payer system in the sense that it only has one risk pool for everyone. It has one uniform benefit package for everyone, and it's a relatively comprehensive one. But it does allow people to buy additional services beyond this benefit package. It is not an opt-out like what Germany allows for the top income people. You can supplement, which is similar to what the Canadian system is. And in a sense that, and the third defining element of a single payer in the case of Taiwan is you also have one purchaser that would pay all the provider, irrespective of whether they're public or private, with one single set of payment method and fee schedule, and the same rules that they use to select who are the qualified providers to be contracted by the insurance fund. So in that sense, there are 3 ones as a one single payer system. Now, before 1995, Taiwan actually has set up different kind of insurance schemes. In 1950, it has set up labor insurance, mainly for people who work in the formal sector. I mean, this all sounds very familiar in all countries, not just in the advanced economies, but many other countries in the world that is now having healthcare reform. Usually it starts with labor insurance in the formal sector. Then it is also the civil servant, government employee insurance. But then Taiwan also later on expanded and established a farmer insurance to insure everybody who is a farmer, and then later on low-income household as well. So before 1995, about 57–58% of the population is insured by different schemes with very different benefit package, different payment schedule. It's a multiple insurance system. And in 1995, the government legislated the establishment of a national health insurance scheme that merged all the previous insurance scheme and then also bring the uninsured into that one single scheme. Now, if they are all in one risk pool, and I'll talk about the difficulty and what is the compromises the government had to make in order to bring everybody into one risk pool. Now, obviously, among the different insurance schemes, the one that has the most generous benefit package is the civil servant scheme. And if you're going to offer one identical benefit package for everybody now within one risk pool, well, you almost have no choice but to start with the most generous one. Because if you start with anything below the most generous one, the one that currently is enjoying a very generous package, they would never be willing to be part of it. So the initial benefit package started with inpatient care, ambulatory care, all the tests and examinations, prescription drugs, and some of the OTC drugs as well. But then due to political lobbying by the dentist and the Traditional Chinese Medicine Association, they were also added. So it is very comprehensive by all means. And they also cover daycare for the mentally ill and also home care for nursing services. What is being excluded will be immunization and vaccination, because this is regarded in general that should be the government's role in providing anyway. It's not an insurance role. And also cosmetic surgery. And if you want to stay in a single room or a room with double occupancy, you also would have to pay for it. National health insurance will not pay for it. Some non-prescription drugs, denture, hearing aids, etc. And also long-term care. And I highlight long-term care is because there are implications of the aging population now. This was designed 23 years ago, and 3 years ago, Taiwan also celebrated its 20th anniversary. Very comprehensive benefit package. So the question is, how do you fund it? The general rule at the time was, overall, the system should be funded approximately 1/3 by employer, 1/3 by the government, and about 1/3 by the insured. How it works is, for the formal sector and government employees, of which you can do direct payroll deduction, the contribution initially is 4.25% of their wage, shared between employer, employee, and a little bit of government subsidy. For those who are not in the formal sector, the government basically levy a fixed amount of premium. So there's inequity built into it, of course, because if you are an individual practicing lawyer versus your individual practicing selling things on the street, your income is obviously very different. But if there's no data that would allow the government to be able to do a direct payroll deduction, then many of these people are basically asked to pay a fixed amount of premium. So the rich people are essentially benefiting, whereas the poorer will be paying more than its share. But it is a way to bring everybody into the scheme. But in order to reduce the inequity, what happened is that the government also put up quite a bit of money, but targeting the informal sector and the poor. And this is a lesson, perhaps not for the US, but for many middle-income countries nowadays that is trying to bring the informal sector into some form of risk-pooling mechanism. The lesson, by and large, is that there's no magic bullet. The informal sector, in particular, the working informal sector who are healthy, they would not want to join it. What Mark referred to this morning, adverse selection. And the only way you can bring them in is some form of government subsidized premium. There's really no other magic that you can find. And in the more rural places and in communities where you can still find forms of solidarity, or what we call social capital, and this is happening more in middle-income countries, in the rural areas where people feel that they're sharing something, you can still get them to contribute into this risk pool. So either government subsidy or there is some kind of sharing among faith group or others. So you will notice on this diagram, on this table, that the government subsidizes the unemployed, the veterans, the poor 100%, and the military prisoners as well, and even the farmers and fishermen. That's the share of contribution across the three sectors. What enabled the government to be able to do that at that time? Well, Taiwan introduced national health insurance at a time when the economy is booming. This is almost universal across the world. When you want to introduce anything that requires additional funding, it has to be when the economy is booming. From the government's perspective, bigger fiscal space. From employers' perspective, when their income is rising, it feels much better. The second common factor contribution is politics. Taiwan was able to do it because it was a time when Taiwan was transitioning from a one-party rule to democracy. And the president then, Mr. Lee, he was convinced that he needed one big social program on his political agenda. So he really pushed this forward. And when it was legislated, eventually, it was also given such high priority that it wasn't placed with the Ministry of Health to plan it. All of you know that around the country, the Ministry of Health is actually pretty low on the entire political agenda. It was actually placed in the hand of the Planning Commission, which is much more powerful in bringing about coordination and additional resources. So those are the factors that made it happen. But people do have to pay a co-payment. For outpatient services, if you go to a clinic for one visit, they pay about $1.6 of US dollars as of today. But if you want to go to a big tertiary facilities for an outpatient visit, you pay $12. So there's rationing in that sense. For inpatient care, the co-insurance rate vary by the length of stay, but it's also a ceiling that would cap at the certain amount of the income. So each admission, the co-payment would not be more than 6% of the average national income per person, and for the whole year, not more than 10%. There are also exemptions who are being exempted for co-payment. If you're low income, you are veterans, or if you're children under 3 years old, if you live in remote area, meaning mountains and island areas, then you don't have to pay for co-payment as well. So it is a policy very much designed to protect the poor and the vulnerable, and assuring that there is equity. Now, I'm not showing any data here, but there are lots of academic studies which have shown that since Taiwan established national health insurance, access to care has improved, but more importantly, access to care between the rich and the poor has drastically narrowed. So that's one major consequence of this risk pooling and comprehensive benefit package, that is affordable and also equitable access to health care. But I would also caveat to say that most of the studies, when they say access, is very much measured by utilization. But of course, you know that utilization doesn't necessarily mean good care. And that's probably where the fundamental challenge is. Now I come to the third one that I mentioned. Taiwan established the National Health Insurance Administration and act as a single purchaser that buy care from all the providers. And as of today, 93% of providers in Taiwan, whether it is public or private, has a contract with this National Health Insurance Agency. And using the term of an economics terminology, this NHIA basically holds monopsony power over the provider. It can negotiate prices with the provider. It can also set payment rates. And in a way, it is in a position to say to the provider, it is a take it or leave it offer, because I do have 93% of the market. Now, in fact, national health insurance covers 99% of the population now. It is 99% of the market. It is in my hand. And similar to Canada, even though it is largely publicly financed, the delivery system is largely private. In outpatient services, I would say about only 8% is delivered by the public hospitals. The rest of them is either in clinics or in hospitals. And in fact, the majority is in solo practices. Now, this has important consequences later on when I talk about the current challenges, because like in Germany, the majority of the outpatient practices are actually specialists. There's very little primary care. In fact, they provide curative outpatient services. So many countries was aspiring to the UK for primary health care. So I was a bit disappointed this morning that Anita feels that even the UK is falling apart in primary health care. So we should discuss that. And how does Taiwan try to make sure that its system will be financially sustainable on a long-term basis? It has a very comprehensive benefit package, even with some co-payment, and it's contract public and private providers, and it has adequate supply. So what it does is that it sets a global budget for the entire system, not a global budget for a hospital. And then within that, it has a fee-for-service payment system based on points. So let me elaborate a little bit. This actually has a lot of similarity to Canada and to Germany as well. At the beginning of a year, the Ministry of Health will propose a budget increase to the cabinet. The cabinet would then approve what will be next year's budget, okay, for national health insurance. And what is that based on? It is, of course, based on its expected revenue increase. Since it knows what is premium contribution, it can predict what is the wage increase, it actually can predict what is the growth of premium increase every year. So the cabinet basically said that for each year, the budget for the national health insurance is capped, and it is a hard budget. Then what should that budget be spent on is then based on negotiation. In that sense, very similar to Germany. Taiwan has a committee called the National Health Insurance Committee. It consists of 10 members from providers, hospital, physicians, dentists, etc. Another 2 government officials who mostly represent the payers from finance, because a large amount of the money is paid by general tax revenue. And what is interesting is also it has 5 members from the academics. You will notice that except for the academics, everyone who is represented in this committee represent either the interests of the payer or the provider. So it needs someone who is neutral, but also has the technical knowledge to be able to basically moderate and mediate if there is any conflict among the different members. And this committee would then decide on what exactly will be the budget for each year. Now, there are 4 budgets. One is for dental care, one for Chinese medicine, one for Western medicine clinics, and one for hospitals. So about 70% of the budget actually goes to hospital. And hospital, within the hospital budget, actually about half is for inpatient services and half is for outpatient services. And you'll be a little bit miffed by why the budget is not given according to service, why is it given to facilities? And the argument is that for each of the budget, actually the National Health Insurance Committee would work with the relevant professional association to decide on how the money is being spent. And since the Professional Association for Hospital and the Professional Association for Individual Physician Practices are different, this was the rationale of how the budget was being divided. And each year, the budget for each sector, so for example, for hospital, what the budget it is set for the year, next year, would be based on 2 parts of the budget. One part is called basic benefit, one part is called special program. And of the basic benefit budget, it is basically last year's budget plus a growth rate. And what is that growth rate? The growth rate is separated to 2 sets of factors, one set non-negotiable, one set negotiable. The non-negotiable factors are basically things that are natural growth. There's nothing you can control about it. And they pretty much consist of the growth in the number of enrollees, which is proportional to the growth of population, and the growth in cost due to aging, and also the growth in medical consumer price index. So these are non-negotiable. But there's another set of factors which is negotiable, which is then dependent on the expansion of the National Health Benefit Package to cover new procedure, new drugs, new devices, but also targeted efficiency gains. So this is all negotiated among that committee. And just to give you an example, for hospital sector, across the different years, the growth rate varies from about, I would say on average, it's always about 4 to 5%, because this is to match the revenue growth rate that NHI, the National Health Insurance Fund, has. But then the distribution between negotiable and non-negotiable tend to differ a little bit. And what is the advantage of that? The advantage of that is it allows the scheme to not just look at cost control as an objective, because many of the non-negotiable, the negotiable factors is about expansion of services. It's also about if some of the services is identified to be needed to expand to a rural area or to some underserved population, it also comes into this negotiable factor. In other words, it allows the growth rate to take into account both the need to keep up with costs, but also the need to respond to rising demands and needs of the population. And of course, politics do come in. Now, after each sector gets a fixed budget, how are the different providers being paid? The providers are actually being paid according to a fee schedule, but the fee schedule is not based on dollar value. It's based on point value. The fee schedule is inherited from the labor insurance before. And the points for each service is actually not based on cost or productivity. It's just based on historical reason of why it is being there. And so, as a hospital, you will still bill national health insurance according to the fee schedule, but you only bill according to the number of points, okay? So let's say in 1 year, for one particular region, the total budget allocated for that region for hospital is 10 million. If there are 10 million points that are billed by all the hospitals within the sector, well, each point is worth $1. But if the total number of points that are billed is more than 10 million, you divide 10 million by the number of points that are billed, your dollar value is less than $1. So this is a very clever way to always keep the total payout to be exactly the same as what the budget has, by adjusting the dollar value of each point. So Taiwan is very successful in controlling costs in that sense. But there are implications, because the incentive for the provider is still fundamentally fee-for-service. So in the initial years, what happened is that if I am one of the hospitals in a region with 10 hospitals, well, what am I going to do? I am going to be afraid that if Vivian Hospital is going to bill a lot more, the dollar value of each point is going to be reduced. I will be losing out. So every hospital has the same mentality, so every hospital tries to bill more. So the initial years, I think that happened in Germany as well. And in the initial years, the conversion factor dropped by about 30%, because everybody is doing more. And in fact, what do they do more on? Well, let me show this first, and I'll come back to it. Let's use the hospital budget as an example. Before 2002, it's just a fee-for-service payment system. The global budget system that I described to you with an adjustable dollar value for the fee schedule started in 2002. You will notice that from 2002 onward, the vertical bar represents the number of cases, that is, number of admission. It has been growing, but not that much. But this green line represents the number of points that is being billed, and it has gone up quite a bit. What does it mean? It means that per admission, many more points are billed. What does it mean? It means that for each admission, doctors do a lot more stuff to the patient. And there are analyses to show that what do they do more? Obviously, you're not going to do more surgery. You do more diagnostic tests. You prescribe more drugs. So I would say Taiwan is very effective in controlling health expenditure growth, but not so well in improving efficiency. I think they are very different issues. So if you go back to looking at health expenditure growth, yes, between 1996 to 2002, health expenditure grew at 5.7% per year. National health insurance grew at 5%, and out-of-pocket about 5%. And then after the hospital global budget is being introduced, the growth rate has tremendously reduced. So if you think about growth of the controlling total health expenditure or national health insurance expenditure, it's very effective. But if you think about efficiency, there's a question mark. Okay? So this is, I'm just trying to show, let's say if we focus on the hospital line, the conversion factor in 2002 Starting from 2000, it drops from 1 to just about 0.7. Now, why does it go back up again? In fact, the National Health Insurance Agency now has to get all the hospitals to sit down together and say, the fact that you all independently bill a lot of points is not helping you because you're not earning more. And it's actually causing a lot of waste in the system. They almost have to get the hospitals to come and sit down to come to some negotiation to not do a lot of extra unnecessary thing. What is the effect on quality? Because universal health coverage is not just about insurance coverage. It is also about whether people are getting good quality care. And I would say that on that score, Taiwan's data is very, very limited. And there are some studies that actually look at, does the global budget actually in fact lead to quality differences? Some of the trend analysis, let's say the one using AMI or pneumonia as a tracer condition, did find that before and after global budget was introduced, mortality rates and also increased use of emergency actually have gone up. But those are only trend analysis. The only analysis which is much more rigorous by comparing before, after, and a control group, analyzing about 400,000 of stroke patients, also found that there are some increase in mortality rate, but there are also improvement in adherence to some of the process of care. So I would say that the evidence on quality is mixed, and there's not enough evidence and focus on that at all. What are some of the lessons? I would say that how Taiwan designed its single-payer system is very effective in providing equitable and affordable access to health care and also providing financial risk protection. That's a good lesson. And as a single payer, it also commanding a lot of market power, it is also able to control price and manage healthcare expenditure growth rather effectively. And there's an added benefit of what this single payer can do, which is something that I heard this morning that the 3 countries said that they are doing horribly in. And this is an area Taiwan is doing really well, and that is its IT system. Being a single payer system, all the claims has to go to the same agency. And because it covers comprehensively inpatient, outpatient, and drug, National Health Insurance Agency has the full profile of every hospital, of every physician, of every patient, and this is all brought together through one single IT system. And what does it allow the National Health Insurance Agency to do? It can conduct utilization review and identify whether patients are actually given care very much along clinical guidelines. And how does it do it? It actually engaged the professional body to work with them. In other words, instead of being a National Health Insurance Agency telling the professionals you're not doing the right thing, it actually engages the professional association themselves to be doing that job and giving that message. And I think that is very smart, because in everywhere in the world, the insurance funds always is viewed upon as, I'd like you to pay me, but you're the bad guy. You always say that the provider is doing too much and unnecessary thing. The second thing that it allows what they can do is they can do provider profiling and identify providers of a certain specialty doing a certain health procedure, why this provider is doing many more than the other providers, why a particular provider is prescribing more drug than necessary, and then identify them. And finally, this system has been used effectively to identify frauds. And in fact, initially, in the first year it was being used, it discovered that 8% of the claims that is being filed are falsifications, and it's now gradually lowered to about still 1 to 2% of it. And it's not a small amount of money, 1%, 2%, 8%. And duplication of service has also been reduced because every time the patient comes in, you do have an IC card and you plug in an IC card, you can see the entire profile of what drugs have been prescribed to this person, what test has been done. There's no justification of repeating any test. Any test that is being repeated, actually, the National Health Insurance will not pay them. So in a way, Taiwan is doing really well with this single IT system in managing use of services. And now, you might be asking me, what is the administrative cost? Because most people think that a single-payer system is actually very, very expensive to manage. I would tell you that Taiwan has always been able to manage that administrative cost is only 2% of the total claim value that they spend. And because there's very little fragmentation, you just deal with one system. Now, what are the challenges? Even though Taiwan is able to manage its health expenditure growth, but there are natural courses of growth. And as Stephanie referred to earlier, as the economy changes, much of the contribution to GDP is not coming from wage income. And so when your premium contribution is always tagged to just wage income, your base is getting smaller and smaller. And there's also the pressure from technology, the pressure from aging, all these natural forces. So those are things that always come up in a political campaign in every election. The system is going broke. But then when you ask people, shall we take away national health insurance? No, we don't want to. Does it sound familiar? And so what Taiwan has been trying to deal with is increase a little bit of premium, increase a little bit of co-payment, but I would say all these are very politically charged. Every time you want people to pay more, no. So what Taiwan is trying to do is increase the base, including taxing on stock dividends, bank interest, rental income, and bonus payment, etc. And Taiwan is trying very hard to introduce provider payment reform, moving from that fee-for-service based fee schedule to DRG. But I would say that 15 years ago, when I first started in Taiwan, they say that they have introduced 400 DRGs. When I was there last year, it was still 400. Well, when you pay provider by fee-for-service to start with, they love it. It's just very hard to move it to another system. And they're also trying pay for performance, but only for isolated cases, and it's on voluntary participation, but it's an effort. Now, another challenge that the system is facing is that although Taiwan is very good in controlling its healthcare expenditure growth, I think some of the data is saying that it might be controlling a little bit too much. If you look at this graph, this red line shows the share of total health expenditure due to private insurance. It's about 15%, but it's rising very fast. And what is that on? Part of the insurance policy is to pay for is bought for co-payment or to buy or for single room occupancy, but there's quite a bit of that is to pay for things that is not covered. And what are the things that are not covered? They tend to be new drugs, new medical devices. So there is a question of, well, the government should assure everybody have access to basic things. For these new drugs and new medical devices, if you can pay for it. It is not the National Health Insurance responsibility to have everybody have access to everything that is new. So that's one argument. But the other argument is it going too overboard to the extent that it is stalling technology diffusion? It's a question that has been debated with no clear evidence for answer. But certainly private insurance is really rising. Aging population is an issue in China, and what China has introduced, Taiwan has introduced since last year is a long-term care insurance, which is also a public insurance scheme based on the principle of a social insurance. But I would say that the major challenge that Taiwan's health system faces is what Mark mentioned this morning. The delivery system is a silo system. It's a fragmented system of which the hospital and outpatient services are completely separate. And there's very little primary care. And if you think about a population that is aging with increasing non-communicable disease, chronic conditions, a hospital-centric and a fragmented system is the worst delivery system you can think of. But how do you change that delivery system is going to be a major problem. But I would say that to the extent that it has a single-payer system that actually represents 99% of the population and pays for 93% of the providers, it gives them more room to try to introduce different kind of payment incentives to leverage a delivery system change. So thank you very much. Food for thought. There's a question in the back. There's a question in the back. There's a question in the back. There. Sorry,
I had a question about how new drugs and new medical devices are the primary factor that makes the private insurance costs to increase. Do you have like a specific breakdown on these new drugs and new medical devices? Because I'm also aware that a huge portion also is related to cancer treatment.
There's very little private insurance data. As you can tell, private insurance data by definition is proprietary. So there's actually very little analysis of what that private insurance is based on. But new drugs, new medical devices, at this moment is not the major contributor yet. Because if you look at the majority of private insurance in Taiwan, they are all what we call rider policies. They are policy bought together with life insurance. So a lot of them actually are paying patients a fixed amount of money per day based on the number of days that they are hospitalized. That's the majority of it. The rest of them is allowing them to go to private rooms. There's only a small amount of it at this moment that is bought for cancer. But I'm sure that will be a rising share. And it depends very much on how the National Health Insurance will incorporate the most basic drugs into it. So at this point, National Health Insurance do cover cancer drugs, but it may not cover the newest cancer drug.
If you said this, I missed it. What percentage of the Taiwanese population would utilize Chinese medicine as opposed to Western medicine?
I think it is. So if you look at the entire budget, 90% is already spent on Western medicine, so the part for Chinese medicine is small.
Okay, this whole point system thing is fascinating, and I just would have thought you could move the providers over to bundled payments if, for example, you said, okay, all hip replacements next year, we're going to go through the data and figure out how much we spent on hip replacements last year, and then you're going to get a bundled payment per admission. So you control the costs, and you also get the hospitals on board, because then they don't have to be worried about how much they're billing for that particular service.
I think that there are lots of rooms for Taiwan to move towards bundled payment, more capitation-based payment, so that it would incentivize them to send people out of the hospital when they're ready for rehab, or sending people out back to the outpatient setting. And I think it's just slow and taking a little time, and I think partly it's because I do think that the provider at this point is still very much in the mentality that they're so used to acute care treatment, and a fee-for-service kind of payment is more consistent with that practice mode. Anytime you use a bundle payment, it's asking them to ideally work with another partner. But it is a fragmented system. How do they cross the border to work with another partner? That is the fundamental difficulties. But I truly believe, in fact, that's what we're doing a lot of experiments, but more in China and India, is moving from these kind of episode-based payment system to more a population or a patient-based payment that actually would force the provider to come up with their own innovation to coordinate with someone else who is right now completely disintegrated with them. Because I'm of the belief that it is impossible for a national health insurance agency or for the government to say, I'm going to legislate delivery system change. The one lever for a single payer like Taiwan is to use payment incentive to make that change.
Well, one benefit Taiwan has is you have one single EHR platform, right? So there's no interoperability issues like we do here. So
from the insurance agency's perspective, there is no problem of portability. From a provider's perspective, there is no problem as well. That's why I do think Taiwan is in a better position to go towards more bundled payment. It has the right preconditions there. And that goes back to when you have a single payer system and a single information system, it just gives you the precondition for many other things that you would like to do, but you haven't been able to do in the US and many other places.
Okay, my favorite question, social determinants of health. I haven't heard any mention, and the whole issue of patients with chronic problems. So is that even on the radar, looking at housing, transportation, food, things that lead to health care poor outcomes?
I don't think in Taiwan there is that much attention to housing or transportation yet. There is attention to food labeling, but I would say that in general, if you look at, the typical thing we look at, let's say for hypertension, diabetes, what percentage of people with hypertension actually has been diagnosed? Among those diagnosed, what percentage has been managed? Among those managed, what percentage have been controlled? It is bad. It is bad partly because the majority of these outpatient clinics, they're really doing curative care. There's no mandate in them to do population-based disease management. In that sense, Taiwan is doing badly because they are learning from the three countries that they So they are, you need to go back and teach them now. So they're doing not very well on that. But let me answer your question about housing, which is what we call the health in all policy now. It is very difficult. Technically, it makes sense. it is very difficult is because housing, food, transportation, they are all governed by different ministries. There's really no reason for any ministries to come together to try to devise a policy for health. Unless you have a supra ministry, or in your government structure, you have a ministry that looks at above all and also have recognized that health is an important contributor to economic growth. This is just observations around the world. It is very hard to get the different sectors to coordinate because all the other sectors always have economic growth as the priority, and health is not on their agenda. If you look at smoking, tobacco control, in many countries, the tobacco policy is actually in the Ministry of Commerce. It is actually not in the Ministry of Health. What is more important is the commercial interest that dominates health. And this is just a reflection of how some of these health issues, when they're in conflict with commercial interests, it's very hard to align. Yes.
So Taiwan is a fairly small country. Do you think that's been
It's not a country.
Do you think that's an advantage for it in making it administratively efficient, or like getting everybody on board on the same IT system? And at the same time, do you think there are challenges when we translate and transfer lessons from a country like Taiwan to larger countries like US or like India, like we were discussing before?
You're absolutely right. Taiwan has only a population of 23 million. I don't imagine that a country like, I don't want to use US as an example because it is not just about size. I think in the US, both politics and the entrenched interest group are more important factors in determining where we can go rather than technical analysis. But if you would say, take Taiwan system to another country that is bigger, the principles that it used doesn't have to be applied to the whole country. It can apply to a province and a state of similar population. It's not going to be identical, but it's the principles that it can draw on.
In other systems, they used the regulations in terms of guidelines and accreditation to reduce the cost. So in other words, there are guidelines that commit the providers to behave in certain manners, otherwise they lose points from the accreditation, and this being central. Another way is to purchase the pharmaceutical products through one national bid, which in some countries it reached like 60% or less of the market price of medicines, for example. So is this the case in Taiwan, these
Right.
measures?
So accreditation is done throughout Taiwan, but I would also quote international experiences. I would say accreditation only gives you the floor of quality. It doesn't really improve. It is not really associated with improvement in quality beyond the basic level. So clinical guidelines. How many systems, if you introduce clinical guidelines, how many doctors actually use it and follow it? If you do not tie it with some sort of incentive or some sort of accountability system. So clinical guideline, I would say necessary, not sufficient at all to have major change. Taiwan actually negotiates pharmaceutical prices aggressively. Again, being a single purchaser, that is what it is able to do.
Have you used compulsory license? Have you used measures like compulsory licenses for new medicines?
Yes, Taiwan does that. It also uses reference pricing to compare its price to 10 advanced economy as well.
I don't think I saw, what is your average cost per capita and how does that compare to the other systems?
I'm sorry, I should have said it.
And I assume it's lower, and is that perhaps, is there a health disparity issue, or because it's just one payer, or perhaps more cultural issues and the fact that it's a relatively homogeneous population?
So Taiwan spends about 6.4% of its GDP on healthcare, and the growth rate has been maintained at about 5%. And if you take away population growth, it is about 4.4%. So if you compare 6% to OECD, of course, it is still much lower. But we also know that there are a lot of regional differences. So let's say if you compare Taiwan to Japan, to South Korea, which is more similar in the Asian region, I mean, Japan still now spends about 10% of GDP on health. South Korea is catching up by spending about 9%. So I do think that comparatively to OECD or to other Asia region, Taiwan is doing quite well in terms of how much is spent and also the comprehensiveness of the benefit package. Now, there's some inequality, mainly for people who lived in mountainous areas. But that's a small percentage of the population. And part of that is just culture. There are just people who have been in those areas that it's just impossible to move them out to the city. Waiting time?
No. I wanted to ask about the academics you have on this negotiating committee, because anybody who's ever been to an academic faculty meeting knows how dysfunctional we are, and I can't imagine that they actually could help in a very contentious situation like this.
Maybe the academics are more dysfunctional among their peers. Well, the academics are not from the same institution, but the academics, what they do is, I think what the academics does is they present evidence and data. It's not so much that they make a decision. That's why I said that they play more of a mediating role, because obviously if you are the payer or if you are the provider, you always try to argue on things more for their interests. So the academics mainly play that role. Now, it's interesting that actually some of the academics has become the CEO of this national health agency, insurance agency. Some of them have been, for a few years, been the Minister of Health. So there's in that culture the mix between the academics and the government as well.
A quick question. In the early years, in '95, when this was implemented, how did that go about stopping fraud or fraudulent claims without an integrated IT system? The reason I ask this is, suppose you implement this in a country like India, where integrated IT systems would be hard. What were the initial lessons that was there?
My answer is, it is not possible. Because when you have everything paper record, it is just not possible to detect fraud, and providers always can come back and tell you many reasons why they do what is, unless it is falsifying a claim. But, it is so difficult. I mean, the cost to do it is actually more than what you will be able to detect. And so, I mean, since you mentioned India, India is now trying to roll out a universal health insurance scheme that would cover about 40% of its population. And then when you talk to the government people, they are preoccupied with setting up an IT system. They haven't designed their benefit package. They have not estimated how much it costs to provide that services. They have not estimated the price that they pay the provider would actually be affordable, nothing, but they want to roll out an IT system. And I said, well, you don't know what you're going to pay for. Why do you need an IT system? Actually, it's because in another smaller scheme, they know there's so much fraud. So the IT system is driven by the need to reduce fraud rather than to make the system more efficient. Thank you.
Thank you so much. That was a wonderful talk, and thank you for all your questions on this. Just going to conclude. There's a lot of material, so I'm not going to try to summarize it or anything, but just a few things, big observations that, I think that there's a lot to learn from different healthcare systems around the planet. Every country has its own history, and they deal with it in different ways, and there are always these trade-offs you have to deal with. There's no perfect system. Every country has its challenges, and wealth inequality, for example, in Canada is going to be an issue. The countries which are more homogeneous, let's say like Taiwan, may have less of those issues, but as wealth inequality increases, things may change. One thing we also noticed here was the strong presence of a public sector. That's something which is common across all the 4 examples. There is no question in this thing that if you really want universal health insurance for everyone, the public sector plays an important role based on all these experiences. The mix may vary, the delivery systems may vary, but that idea that that there is you kind of have to give a priority what you care about. Do you really care about covering everyone, or do you care about, let's say, the moral hazard issues about maybe if you cover everyone, there'll be free riders, and that thought obsesses you. And that is partly a political issue, which was mentioned too. If society is extremely polarized and they just think everyone is a free rider, so that fundamentally goes back to the values, or values and kind of traditions, right? How do you build up solidarity in diverse societies which have increasing wealth inequalities, right? And how do you adapt your systems over time with different conditions? So I think there is the key lesson for me, and was there is it's important to really pay attention to the context, and there's a lot of heterogeneity and diverse experiences, and one needs to keep a careful eye on different systems and learn from each other. I just want to thank everyone for coming here. Really enjoyed. Thank you all the speakers. We can have a round of applause for them. I want to thank you all for coming, of course, and all your fascinating and great questions. I want to thank Vivian Ho, Brenda Lemons for organizing this this conference and making it happen. I want to thank the audiovisual team as well as the event planning committees to make this happen. And thank you all. Take care.